Memorial Award and Gold Medal for being the university topper of the 2018 batch of MD Microbiology. And she have published several publications and projects, and also she is the professional membership of Infection Control Academy of India, life member, and so like Clinical Infectious Disease Society, and also she's a member of European Society of Clinical Microbiology and Infectious Disease member. So we welcome you. We have a distinguished speaker here today. So as I've mentioned earlier, you have a great speaker here and great opportunity for you all to resolve all your queries after the session, and also you will have a great insight out of the session. Welcome you, Doctor.
Yeah, thank you so much, Stella, for that introduction. And I really look forward to this webinar. And I would like to thank Skills for Med, Dr. Pari sir, Nitya madam, and the entire team for giving me this opportunity. And yeah, so I'm so looking forward to deliver my topic today on outbreak investigations. Yeah. So I think without further delay, let's go on to the presentation. So today I'll be taking you through what is the definition of an outbreak, why do we need to investigate an outbreak, and what are the 10 steps of outbreak investigation, and what is root cause analysis and corrective action, preventive action. We need to know this because most of the outbreaks that we had that happens in our healthcare or in our hospitals, we are it will be like a clustering of 5 or 10 cases, and we need to know the source. So we need to also understand what is the root cause. How do we do the root cause for them? So next slide. So what is an outbreak? So outbreak means it is 2 or more linked cases of the same illness, or a situation where the observed number of cases exceeds the expected number. That means, for example, every month you have been having 5 cases of measles. You have reported 5 cases, and suddenly in the month of October you have reported 25 cases. So that isn't it exceeding than the expected number, right? So that becomes an outbreak. Or a single case of rare disease caused by a significant pathogen. For example, in an area where there is no yellow fever or no Ebola, and suddenly one case of Ebola is confirmed. So that also becomes an outbreak. In our hospital setting, for example, in your MICU, you have had no case of MRSA in the last 6 months, and then one MRSA case props up, and then another in the next 2 or 3 days. That also becomes an outbreak situation. So then what's clustering? Clustering is aggregation of cases in a given area over a particular period without regard to whether the number of cases is more than expected. Right? So you don't have to exceed that baseline in case of a cluster. So I just thought I'll share some, you can go on to the next slide, some interesting articles pertaining to, outbreak situation in healthcare. You can go, can you go on to the next slide, please? It's Stella?
Yeah. Dr. Nitya, we are able to change to next slide.
Yes, yeah. So, in our hospital, if you see, we have had a lot of outbreaks which come from, which are basically water associated. So we have, these are some interesting articles which I found where they have grown Burkholderia from the chlorhexidine mouthwash, and which led to a lot of ventilator associated pneumonia cases. Similarly, your water, especially the water that we use in our CSSD, in our ICUs, all these, if they get contaminated, again they can cause a lot of healthcare associated infections. So next slide, please. Yesterday I was just going through some of the articles, and I also found this very interesting article which said the New Delhi metallo-beta-lactamase Klebsiella, which is actually an XDR, extremely drug-resistant Klebsiella, being isolated from the toilets and causing nosocomial outbreaks. So it's very important. That's why we keep stressing upon cleaning and disinfection of each and every corner of our hospital. So with these examples of outbreaks in hospital settings, now let's see why we actually need to investigate an outbreak. So you all already know, 20% of all our ICUs are filled with hospital acquired infection, may it be urinary tract infection or a bloodstream infection. This is causing a lot of mortality and morbidity, and then the patient has to bear the cost, and then there is increased length of stay because of these HAIs and spread of HAIs from one patient to other. So so we need to investigate them, find the source, develop strategies to prevent them, right? So that we, and then again, if this kind of situation keeps continuing in the hospital setting, will it be a bad reputation for the hospital? So again, it's very important that you start investigating, and it's of public health significance, like COVID. Like for example, COVID was completely a new disease for us. We didn't have such a scenario prior, but only after investigating the disease, we found out what is the cause, what kind of mask we should wear, what are the infection control measures we should follow, what are the vaccines we can develop. So it's very, very important that each and every outbreak that occurs in your hospital setting is investigated completely. Right. So with this, Stella, can we just have a poll here before going to the 10 steps of investigation?
Sure,
We
doctor,
can,
sure.
yeah. So
So there is a poll, is it?
yeah, there's a small, yeah. Will you be able to?
Yeah, I'm bringing it up, ma'am.
Yeah. So for all of you, I have three questions here. You can, you have to just say yes or no. And this will tell us whether you understood what really an outbreak is. So,
Very good. They have started to answer for this poll.
yes. So in a surgical ward, there were two cases. And will you be worried? Yes. So will it be an outbreak or no in these conditions? So in the first case, see, there have been already 3 cases of breast abscess. I think they have not finished the voting, so
No,
I'm
no,
not.
they are just answering. We can give them some time, doctor.
Yeah, yeah. I'll
So,
wait for
yeah.
telling the answer.
So
Yeah,
30 seconds have got over.
yeah.
Let us wait for them to.
Yes.
But they are very quick at answering it.
Yeah.
So then I'll share the results, doctor, on the screen. You are
Yeah.
able to see this, like you will be able to see the screen when I share the results.
Yeah.
Okay, so we will have the discussion. Okay, so I'm going to end this poll here. So thank you so much to all the participants who have logged into the poll. So yes, doctor.
Yeah.
Can you
So
see
in the
this here?
first case scenario, you have 3 cases of MRSA every month in your surgical unit. And then again, this month you have reported 2 cases. So will you be worried? Yes, definitely you need to stop infection control. But if you take in infection outbreak perspective, this will not be an outbreak. Right? So yeah, I think 26% answered correctly. This will not be an outbreak, but yes, you have to be implementing your surveillance practices. In the second question, yes, now you have had 3 cases and now 6 cases. Definitely the case is more than the baseline, right? So here you have, there's an indication that it may lead on to an outbreak, and this you have to act more fast, and you have to be more vigilant in this scenario. And yes, in the onco unit, there has been no case of aspergillus and suddenly one case of aspergillosis. Yes, it may be an outbreak. You have to start investigating. So, yeah, I think we can proceed further. There's some clarity among everyone on what they have to consider it as an outbreak. And with this idea, I think we can go on to see how we investigate the outbreak using these 10 steps. So, next slide, please. So,
You see this? I moved it already.
okay, I'm not, yeah. Ma'am, I think, Next.
No? Now can you see?
I'm able to see the 10 points. I want to go to the next
Oh,
one.
next one. Oh, sorry.
Yeah. So I'm going to take you through these 10 slides, 10 points with the help of a case scenario. Okay, let's see how we can investigate and having a case scenario in our mind. So you have a baby who's admitted. I'm taking a situation of an NICU where you have a preterm baby who's admitted, and in on 17th of this March, and on 2 days after, the baby's WBC counts are increasing and the blood cultures were sent, which on 22nd has grown Burkholderia. Okay, have this in mind. You have a baby who's been admitted in your NICU. 2 days after admission, there is growth of Burkholderia. Right, now the next slide please. So similarly, on a 20th, you had another admission. Again, a preterm baby, moderate preterm baby, and again 3 days after admission, baby was worsening, going into septic shock. Blood cultures were sent. Again, we have a growth of Burkholderia. Now, last 6 months, there has been no growth of this organism in your NICU, and suddenly, within a period of 1 week, you are having 2 cases. Okay, this is the case scenario, and we are going to go through all the 10 steps of investigation with keeping this in mind. Right. So, next slide. So, how will you start your investigation? So first is to identify your investigating team. Form a team. You can't do it alone. You need to have a team to start your investigation. Okay. So can any one of you just type or tell me pertaining to this Burkholderia setting, who will comprise of your team? Who are all will be the members who you will take in your team to investigate?
You can start answering in the chat box.
Yeah,
Yeah, IC
ICN,
and ICO.
ICO. Yes. Yes. Yes, microbiologist, 100% they have to be there. NICU in charge, very good. Yeah, that's a very, yeah. Ward, MOIC, yes. ID, yeah, the physician, ID physician as well, yes. Okay, yeah, NICU consultant, yeah, link nurses, that's also a great answer. Yeah, I'm just waiting for one more. One more. What sister? Yes, yes. Housekeeping staff. Yes, administrator. Yes, that was the answer, because you have to get the resources and you have to convince them, na, ki this is an outbreak is going on. I want a team. I want a resource. So having a person from the administration is also very important. So next slide. So your team should consist of a clinician, an ID physician, a consultant from the NICU, microbiologist, infection control team, nursing in charge of NICU, unit administration, and of course, as you some very well told, you should also have your housekeeping staff also getting involved, especially the housekeeping in charge probably on no, which who they will also help us to investigate the outbreak. So we have done our first step. Now our second step is how to establish the existence of this outbreak. Okay, so there are a few points that we need to see here. You can flash those points, ma'am. Yeah. So always you need to compare with the baseline data. Okay. So whether, as I told you, sometimes even one case can be an outbreak in a ward where there has been no case of that particular organism. So compare with the baseline. Rule out pseudo outbreaks. So what do you mean by pseudo outbreaks? Sometimes, what happens from the laboratory, we may get a false positive result because of a contamination. Sometimes blood cultures may flag after 7 days and still we may get a report of a particular organism. So we need to get back to the lab to check whether it's a true pathogen or just a colonizer or a contaminant. So here probably I would like to say, just no, in short, describe a case where in an ICU they had an outbreak of Burkholderia, and all the patients were normal. The patients did not have any signs, symptoms, but again and again the cultures were coming out to be positive with Burkholderia. So they started swabbing the entire ICU, all the equipments. Twice they did all the swabbing, always the results were negative. So when they went back to the laboratory, the laminar flow hood, which where the culture plates are kept for plating and incubation, were actually contaminated with Burkholderia, and that contaminated the culture plates and gave a false positive result. So you should always rule out these pseudo outbreaks. Then put immediate control measures. So see, you may be working parallelly to working out to know all the 10 steps of investigation, but also you should stop the outbreak further, right? So best thing what you can do first is to at least improve your hand hygiene and also increase the frequency of disinfection in the environment. So immediate control measures should be established. Notify and communicate. You already have an administrative person from your team, so keep notifying whatever you have done, and form an outbreak control team. You have an investigating team, now you need an outbreak control team as well. So now, with pertaining to this NICU case, Burkholderia case, can you tell me what will you do here when you look around these steps? How will you go about these steps? What are the steps you will basically implement, do it for this particular case? So compare your culture reports, right? Compare your culture reports of NICU and see how many Burkholderia you have isolated. Yes, ICU needs to be so increase your disinfection. Go and check whether the babies actually had outbreaks. Babies actually went into septic shock, etc. Improve your staff ratio. Yes, find out which is the common factor, notify. So next slide, I think they have come out with the answers mostly. So patient history as well, yes. So ma'am, next slide. So these are the various things that you will do. Check culture positive Burkholderia in the previous months. Recheck with the laboratory to avoid pseudo outbreaks. Increase your hand hygiene efficacy, cleaning and disinfection protocol. Improve your central line care because these have been bloodstream infections, and set up an outbreak control team. Form a link ICN, involve the nursing in charge, and form your outbreak control team immediately. Okay, so we have finished 2 steps, and now we are going to the third step, which is how to verify the diagnosis. So how will you verify this diagnosis? So again, yeah, ma'am, you can just tap it. So yeah, you have to see there are 2 strains of Burkholderia or MRSA. You have to know whether they are of same strain or they are different strains, because each organism strain matching is also very important. So you can go and send your samples for molecular testing. You can do a MALDI-TOF, or you can do send for sequencing, where they'll actually tell you whether both are same strain or a different strain. Again, review your clinical history, re-elicit the history, and verify this diagnosis. So step 2 and step 3 are almost the same, but here I thought I'll just add a point. How do you confirm it? By certain molecular tests. Like we have a article which says, Serratia marcescens outbreak in neonatal ICU, how they confirmed it by doing a sequencing of all these strains which they isolated, and they found out all were the same strain. So that verification of diagnosis is very, very important, because each may be of a different source. Okay. Yeah. Next slide, please. So this is the answer for it. Contact the laboratory person to confirm whether both the strains of Burkholderia are the same. Recheck with the clinician for signs of sepsis. Recheck the case sheet. Go back and see the laboratory investigations, the biomarkers, and verify the diagnosis. Okay, so now we are in the step 4, and now we are going to see how to construct a case definition. So whenever it comes to constructing a case definition, you basically categorize it into confirmed, probable, and suspect. Confirmed is always a laboratory confirmed case. Okay, probable is with a typical clinical feature of that particular infection, and suspect is when you have few typical features of clinical features of that infection, you call it as a suspect. So in this case, how will you how will you basically go about? You have to go and you will say any case of Burkholderia which is positive from the NICU over that given period of time with clinical signs and symptoms of sepsis is a confirmed case. Probable, again you will define what is the typical clinical feature you want to include, and then you will also define your suspect. Okay, you will form the definitions for them. So now going on to step 5. So now you have your definitions ready, you have your team ready, you have your investigation team, you have your control team, you have verified the diagnosis, and now we come to the systematic way of finding, line listing the cases. Okay, so how do we do this line listing? So here you have various formats for it. So you go on, next slide please. I'll just show you a standard case report format which generally we use in our setting. I think the slides have gone, yeah. Yeah, next slide ma'am. Yeah, next slide. Next one. Yeah, so this is a standard case report format where you basically see whether the exposure is at a community level or hospital level, it's a suspected, probable or a confirmed case, what is the source of the outbreak, and then you follow up the particular case, find out the source, which is the source, and also do a root cause analysis. So this is how your standard case report format for investigating an outbreak should be, right? So next is line listing of cases. Again, once you have filled your standard case reporting format, you start including them in your case line listing of cases. So then all the information you can get it in a single chart. So this is how we go about line listing the cases. Now, step 6 is how do you perform a descriptive epidemiology or develop an hypothesis. So, why do you need to do a descriptive epidemiology? You need to really know, right? You need to find the etiology, you need to find the source, mode of transmission. So, only if you describe the outbreak with respect to time, place, and person, you can actually find out more about the outbreak and arrive at a conclusion. So, for example, in this case, what would you do? Can anyone just say if you have to go about investigating or doing the descriptive epidemiology for this particular Burkholderia case, what will you start doing? So, have you all heard of the epidemiological curve? So you will actually draw an epidemiological curve and see whether it's a point source or a propagated. Next slide please. So you can see you can put a epidemiological curve and then you can compare how many days the outbreak had extended up to, how many cases were reported, when was the peak number of cases that got reported. So all this information will be given when you draw your epidemiological curve. Okay, so now we have finished 6 steps of investigation. Now going on to your last 4 steps. So once you have given your definition, hypothesis, etc., you will basically go on to evaluate your hypothesis. Okay, so how do you evaluate? Go and do a literature review. Go and search whether these kind of cases have actually happened. Okay, how was the pattern of that particular disease. Sometimes you can also do a case control study, a randomized control study, or an observational study. You can publish your findings as a case report. So that is how you evaluate and perform additional studies for this particular any outbreak. Then you implement control measures. So what are the control measures you will basically implement in this case of Burkholderia? I can already see a lot of answers. like NICU needs to be disinfected, verification with other lab. Yeah, that's a very important point which Monica has mentioned. And what are the things? You will start monitoring hand hygiene more strictly, like you can go and see your CCTV surveillance, upscale your disinfectant. If you're using an intermediate level disinfectant, probably go for a high level disinfectant. And again, training and education is very important. And especially your line cares, there may be too many lines in the ICU, so you need to really know whether all the line care or your bundles are in place. And staff ratio also sometimes is very poor, which basically leads to these kind of outbreaks. So verify, talk to your administration and recruit more staff. So all these are the measures that you will implement. And you will communicate the findings. So how generally you all communicate the findings? How do you, what do you mean by communicating the finding? Have a mobile phone, okay, yeah, that's also a nice point. Mobile phone restriction, less traffic in the NICU. Very true. All these are very nice points that you all are, projecting. So how will you communicate the finding? Yes, call for a immediate HIC meeting. And in that HIC meeting, you have to say what and all you have done and what you are going to do in future to prevent such outbreaks. So an immediate HIC meet for that particular outbreak is a mandatory thing that you all should do. Okay. So how, and this all these findings you have to also accumulate and write it like a report. You have to submit your outbreak report once you have finished your investigation. So yeah, next slide, please. So with pertaining to this outbreak, yeah, next slide. Yeah, so control measures I have added. Environmental sampling also needs to be done, right? Whether where is the barcode area coming from? So we have to also go and see whether the environment is where is the contamination in the environment. And then last point was to maintain surveillance. So how long will you maintain surveillance? So any infection, we all know that twice the incubation period we have to carry on with all these measures. So in case of Burkholderia, it is basically the average incubation period is 9 days. So twice the incubation period, at least 18 days after your last Burkholderia case, you have to keep doing the surveillance and enforce strict measures to prevent this spread from one person to the other, one baby to other. So last point will be to maintain the surveillance for double the incubation period of your disease. So I hope all the 10 steps of investigation are clear. Okay. Before proceeding, any doubts in these 10 steps of investigation? Can I move on to what is root cause analysis? Is it fine? Okay, great.
You think they can raise their hands and ask questions, Stella?
Yeah, I think, yeah, we can, any doubts here, we can clear it off before we go to the next segment.
Yeah, even you can, if any doubts before that, you can put it in the chat box or you can raise your hand. We can access and giving them the.
Can you please all the steps? Yeah. So yeah. So I'll just revise. Ma'am, can we go to those 10 steps of investigation slide in one slide so that everyone knows what are the 10 steps and have a summary? So these, so these are the 10 steps of your investigation. So first is to identify your team, have support of your administrator, establish the existence of an outbreak, rule out pseudo outbreaks, verify the diagnosis with your lab and also with your case, construct your case definition as confirmed, probable and suspect. Find the cases using your case report format and line listing of cases. Perform descriptive epidemiology. Use the epidemiological curve techniques. Review literature and also try to publish your findings so that it's useful for others when such situation they face such situations. Implement proper control measures. Have your HIC meet, communicate your findings, and carry on the surveillance for at least double the incubation period of the disease which you are, or the infection you are tackling with. So, is it okay? Yeah, I have a question here. How do we clean a room after seeing a patient with having a high probability? See, it's always after any patient, it is not only an infectious, any patient, you have to follow terminal deep cleaning of that particular room. Ideally, fogging we don't recommend these days, as there are only three situations where you can fog. One is after any repair work or any in your, or a new construction, or if there's any outbreak that has taken place, then you can fog. And yeah, so these are the two main situations where we recommend fogging. If not, deep cleaning of the entire room, whether it's droplet, airborne, depending upon the mode of transmission, is enough in these areas. This one focus only NICU or all areas, ma'am? I didn't understand that question.
I think in scenario you would have given NICU and discussed of that.
Yeah,
Maybe
the case which I discussed is NICU, but that you can apply for any situation, any ICU. You can basically think of these kind of lines of managing your outbreak. After respiratory disease, do we fog? See, actually, that's what. If you have an outbreak in your ward, okay, fog. If not, fogging is not recommended, right? Yeah, so can we move on, ma'am?
yeah, yes, please.
Okay. So now coming to the next part. So generally, whenever this kind of a situation, 2-3 cases of a pathogen like Acinetobacter, Burkholderia, MRSA grow in your ICUs and other critical areas, dialysis unit, transplant unit, you need to find the cause as well. So a very effective way of finding the cause is by this fishbone diagram, which is the cause and effect diagram, you can also call it, where effect is the problem. And this you can not only apply for outbreak, any situation, any scenario in life, you can basically use this fishbone diagram. So what is your problem here? Your problem, for example, is you are having a lot of CLABSI cases. So if there are 3 to 4 CLABSIs, you will go back and see what are the causes that can lead to CLABSI and where the failure had taken place. For example, whether the people hand hygiene measures had failed, or whether the maintaining the line equipment and line has failed, cleaning and disinfection has failed, or proper procurement of PPEs and etc. was not given for that particular department, or your CSSD did not sterilize your central line tray properly. So depending upon your effect, you can basically jot down your cause, and you can also bifurcate it further and find which reason actually led to this particular infection. So next slides, I'm just giving you another case scenario where in your hospital on an average you had 2 to 3 SSIs every month, but this month November already you have reported 8 cases of SSI with growth of MRSA in your post-op ward. So you are called to investigate, and first you have to form if you are asked to do a root cause for this. So what and all will you basically think about? What are the causes that can lead to this kind of a situation? So yes, for hand hygiene, OT CSSD practice, very nice. CSSD indicator, yeah, surgeons, OT temperature, environment, improper disinfection, yeah, and surgical antibiotics, post-operative dressings. Yes, very important. Are these people carriers of MRSA? So you take a nasal swab, yeah, antibiotics, prophylactic antibiotics, skin preparation. Yes, many of us still keep using the outdated betadine. We don't change to alcohol and chlorhexidine based skin preps. So yeah, that could be the reason. Again, shaving is done in many situations. We have not changed to epilators. Yes, clipping, exactly. So yeah, common staff handprint on agar plate. Okay, yeah, you're telling them to do asking them to do a surveillance of the healthcare workers. Yes, maintain care bundle audit. Are they maintaining or not? Check their sugars. Yeah, so you will basically put all these in these costs and see whether where you have actually gone wrong. So I've got most of the answers, and next slide. So here is what you actually can, basically think about patients, whether patients are carriers. Well, did we have more patients with MRSA carriers? So if so, what will you do? You will start screening for MRSA prior to the surgery. Management, whether your OT in charge was not there, whether you had less staff in the OT during the procedure. Similarly, improper storage. Conditions where the CSSD items post sterilization stored properly, or whether the temperature humidity was not maintained, whether environmental disinfection, whether the surgeries happened quickly, whether the time to disinfect between surgeries really happened or not, whether and what type of disinfectant did they use, whether the contact time of was provided or not. All these things we and whether the temperature, humidity, in cases where contaminated surgeries are, whether the positive pressure was maintained in the OT. And then personnel, whether they were following hand hygiene techniques. So whether our pre-op, intra-op and post-op measures were in place. So all these basically lead on to your is you have to include in your RCA to complete this analysis, right? I can see a few questions in chat box. Nasal, yeah, so screen the workers for MRSA. Yes, definitely. What type of PPE should healthcare provider wear for patient visit, including when administration? See, when what mainly you have to wear your gloves, and if I would say mask, nothing more than that. And that too, your 3-ply surgical mask, not N95. Is air plate of OT will identify the infection growth? Yes, it will identify. You have to place it properly. So what happens here is you have these slit samplers which are available now. So they are very effective. But if you don't have a slit sampler, you should ensure that you are placing 4 plates in the 4 corners of your OT, 1 meter from the wall, 1 meter from the ground. That is where you have to place it. And I would also recommend one at the center of your, in the OT table. And this should happen as the first thing of your day. Okay, first after switching on the your air duct, no one should be there in the room. The person should go place these plates, come out, and after a period of 30 minutes go inside, close the plates and immediately send for culture. Okay, so yeah, so once we have done the root cause, next we should move on to corrective and preventive action. So what is this corrective action, preventive action? So here I thought I'll just explain with the diagram. So there's a difference between what is correction, corrective action and preventive action. So if you have an SSI, you have to first treat the infection, right? Or if you have a fire, put off the fire. That is correction. Now, corrective action is what caused the fire. So, for that, you have to perform your RCA. So, when you have to give answers for your corrective action, you should be ready with your root cause analysis. Okay. And what is preventive action? Again, the recurrence of these kind of things should not happen. So, prevention is at a long-term level. Corrective action is immediately to further not to prolong your outbreak, and correction is to cure that particular infection at that particular time, right? So this is what is corrective action, preventive action. So keeping this MRSA scenario in your mind, what could be the CAPA, corrective action, preventive action, for this SSI outbreak that has happened in your setting? Can you start? Yeah. So what
You
will be
can
the
drop your answers in the chat box.
yeah. What would be the corrective action? Yeah, okay, dressing, antibiotic. So you'll first find the source, right? Hand hygiene, okay, training, yes. So whether the bundles, if you had lack of, whether if you found out that OT doors opened very multiple times during surgery, you will go and first stop that, and then see whether it is how many times the OT door is opening in the upcoming surgeries, how the disinfection is happening in between surgeries. Yeah, maintain care bundle. Preoperatively start MRSA screening. Very well said. Corrective is to correct the mistake found out while investigating. Yes, very true. While investigating itself, you should do your correction. Very true. Yeah. So pre-operative checklist is followed or not? Yes. So, ma'am, can you just flash the answer? So, screen for MRSA in these patients with comorbidities, improve hand hygiene by CCTV monitoring, OT environment disinfection, surgical antimicrobial prophylaxis. Are they given within 60 minutes of incision? Okay, all these things we have to say. And preventive action will be to introduce your bundle care, give training and education, and closely monitor your OT environment and provide good surveillance. Right? So, to summarize, early detection is the key. Identify your unusual clusters, and if it is going above your baseline, have your team ready, confirm before you act, rule out your pseudo outbreaks. Okay, and yeah, next slide, ma'am. Act fast. You should all this should be in parallel. You can't go step by step when you're actually investigating an outbreak. Everything has to happen parallelly, so that we contain the outbreak as soon as possible. And yeah, so then do your line listing, form your epi curve, and check whether all the audits are in place. Okay, and all your sterilization procedures, everything is in place. Your environmental surveillance, everything is going on properly. Improve your practices, hand hygiene practice, or the all the infection control practices. Next slide. So communicate clearly, close the loop by doing a root cause analysis, and finally document everything. It's very important you document it, because next time another person faces this scenario, they should be quickly able to know what they have to do. So document your findings always, so that it's useful for others as well. Right? So yeah, I have few questions, I think, which I will just see. If
I have taken the questions for you, doctor. Like in the Q&A portal,
yes,
it is all by mistakenly the answers what they have
what
done.
they have
And
given. Okay.
yeah. So I have picked up some questions from two questions were there from Q&A portal, and some have no missed out during the response from the participants. So I'll
Okay.
read out. One is like, is nebulizer treatment considered as aerosol generating?
Yes, it
That
is.
was chat box. Yeah.
Yeah, it is. Yes.
And one question on how to do the antibiotic audit.
Okay, so antibiotic audit, you have to first form your antimicrobial stewardship team, okay, which I think you can go back and you can get your team. But I would say, see what, when it comes to antibiotic, no, there are QIs. Just like we have QI for hospital acquired infection auditing, we have QIs here. So, like for example, how is whether the dose is given correctly, whether the antibiotic duration is proper. First, it starts from choice, whether the choice of antibiotic was right, whether the duration was right, dosage was right, whether renal modifications were done. And fifth, after you got your culture report, did they actually look upon the culture report and change the antibiotic as per the report or not? Because many times what happens, even after getting the culture report, they will continue with the same high end antibiotic even if the lower antibiotics are sensitive. So that is one of your QIs. Another QI is whether before starting the antibiotic, blood cultures were drawn in case of sepsis from your emergency department. So you have to form QI as per your hospital setting, and then you have to form your AMSP team just like you formed your HIC team, and yeah, conduct meetings regularly as well. So
Yeah, so I have a quick announcement, doctor, regarding this participation certificate. So they are all participants. So as you know, I think most of the participants would have come from Friday webinar even. So, but just to get to know how you will get the certificate for this webinar, to attending to this webinar, like tomorrow after 4 p.m. Okay, so you have to check your mail inbox from where you have registered in your registered mail ID. You check your inbox, or if you have not received any link after 24 hours, check your spam box. So you will have a Google form. Link will be feedback link will be there. So click that link and then fill the form. Within like less than 10 minutes, you will get your certificates in your mail inbox. Okay, so this is the format to get your certificate. Okay, so ma'am, can you move to the next slide now? Yeah, so this is the November event. So successfully we have towards the end, we are completing today's first ICN free webinar, and also upcoming Friday webinar. So on 21st, we have a topic related to preventing SSI in cardiac surgery. 𝐏 series are ongoing. So just join that webinar so that you will get great insights like how to prevent SSI in your units. And this is, we have a great speaker who is Dr. Anand Trita is coming to meet you all during the Friday free webinar. And also we have online CNAs which is running. So for more details, you can contact our admin manager, Jayanti. Yeah, so quickly I run through this, ma'am, so that we can push a bit questions a bit later. Like, is that okay, ma'am? So
Yeah, please. Yeah.
Yeah. So we have conducted a contest on Spot the Error Challenge, Dr. Jyothsna. It is about one picture we have posted in the ICN group. And we have asked all our participants to spot the error. So what are all the infection prevention control compromise have happened? So that image we have posted. So we have got huge response from many of the ICNs. So from out of that, we have runner-ups here. So we are holding the winner at the back. So the runner-ups are Lukudas, Deputy Infection Control Nurse, Apollo Excel Care Hospital. Yes, Mr. James from Apollo Visakhapatnam, and he is a clinical nurse specialist.
Congratulations.
And third person is Ms. Alice Rebecca, ward manager NICU from St. Martha's Hospital, Bangalore. And next person we have Jessica D'Souza, infection control nurse, Apollo Hospitals, Bilaspur. And next we have Murugeshwari, infection control nurse from Bloom Life Hospital, Chennai. And next we have Sitapura Payal Harsukubai. I'm very sorry if I have read your name wrongly. So infection control nurse from PP Mania Hospital. And we have 𝐾𝐸𝐻, infection control nurse, Good Samaritan Cancer Multi-Specialty Hospital from Eluru. And we have Karthik Rana, infection control nurse, Apollo Multi-Specialty Hospital, Kolkata. And we have Parimala, infection control nurse, Fortis Hospital, Bangalore. So next we have the winner who have got the maximum, error. She is Nina CL, infection prevention nurse from Apollo DRDO Hospital. So congratulations to all the runners, and big congratulations to the winner. So Dr. Jyothsna, they have got it right. So as soon as we have
congratulations to all the winners. Yeah.
Yes. And especially when it comes to the Spot the Error challenge, I could see how much enthusiastic infection control nurses are there in the team. So they're very proactive, jumped into that contest, and they have much more to come. So thank you so much for all your participation.
ICNs are always proactive. So
yes,
it's a built-in quality.
Yes, definitely. Thank you to all the runners and to the winner. Thank you so much. And Doctor, let us resume the Q&A session.
Yeah.
So there is one question, in how much height the air plate must be placed from the floor?
1 meter from the wall, 1 meter from the ground. So what you can do is place 4 stools, in your OT, sterile, at least disinfect them, and then place the air plate on top, culture plate on top of them, 1 meter from the ground level. Yeah.
Okay. And next question is when I should be cleaning and disinfecting patient room or other areas of the practice?
Disinfection should happen every ICUs at the frequency of 3 shifts, and if not, at least twice minimum. And if it's an infective patient, you should decide your frequency accordingly.
Okay, okay. And this next question is like if we identify growth like Klebsiella or Pseudomonas in RO water, what we need to do immediately?
So if it's RO water, first go and check, call your RO water plant, the person no, who's managing bio facility person, ask him to check, whether it's RO inlet, outlet, you need to know from where of the RO plant that has got contaminated, whether it's inlet or outlet. And second thing, he has to service it. Okay, and then again, after he has finished his servicing, you again send the samples and see whether they are sterile or not.
Okay, okay. So there are some questions now it have come in Q&A. So how to handle MRSA or ESBL case?
Okay, so all these MRSA, whatever be the MDR, all these, the basic thing you should follow is contact precaution. Okay, one more thing that you get, so follow contact precaution, and if you have 2 or 3 cases of MRSA, best would be to cohort them. Cohort is, you can probably form, if you have too many ESBLs, you cohort them into a particular section of your ward. Okay, don't mix them with the normal case. So cohorting is very important. Following contact precaution is very important. Then third is disinfecting the environment at more frequency and hand hygiene.
Yes, yes, doctor. And what is the source of Burkhold area? So I think
Water.
related to
It's all mostly it's water. It's a saprophyte. It lives, so mostly you will find it in water.
And there is another question. Ma'am, would I like to know if an error occurred, for example, IV drug was given in oral NG tube? What category error is it, ma'am? Treatment has been started for the error. It is category E. Am I right? So
I'm not very sure of this. Yeah.
yes, yes.
Yeah.
Maybe we can get back to you.
Yeah, I'll get back on this. I'm not too sure. Yeah.
Yes. Okay. So corns can be considered as pathogen or contaminant in air culture or swab culture or from blood culture report.
See, it depends. Cons in NICU or in a neonate or even in an adult. Okay, if you have two cultures of cons with the same organism of cons may be Staphylococcus, Hemolyticus, epidermidis, but it should be same organism. Two culture bottles flagging positive with clinical signs of sepsis. Yes, it can be a pathogen. And from air culture, sometimes the methicillin resistance cons is also there. So I would basically consider it as a pathogen and act in if it comes in OT or even in ward in your environmental samples. Only spores sometimes we can neglect, but you have to consider this. Yes.
Okay. I think there is another question. This is also related to today's topic. Do neonatal ICU staff need to wear PPE and consider ICU as closed unit?
Okay, so it is the how much PP you wear. So we generally recommend at least mask, then cap, and the apron or gown based on the procedure which that particular nurse is going to perform, and always gloves is mandatory. So, and also for the attenders, especially mothers, we generally recommend autoclaved gowns. If you don't want to spend on the disposable gowns, autoclaved gowns can be given to them, to the mother, and they should, after a single use or probably 1 or 2 uses, they should discard them. They should not keep reusing them for the entire week or the entire stay of that particular baby in ICU. So, generally, if you take CDC guidelines, they'll say not required. All these PPs are not required. But let us see Indian scenario. We let us use at least mask and gloves and mask in the NICUs. Yeah.
Yeah, yeah. And there is one practice they are following. They want your suggestion. They're keeping blood agar plate 1:1:1, 1 meter above the wall, 1 meter above the floor, and for 1 hour. Is this the right practice?
Yeah, right.
Yeah.
It is right, but no one should be there in that room, and your AC duct should also be on. Just remember that. Yeah.
Yeah.
Mm.
So then, are we allowed to keep water in oxygen chamber?
Every day you need to change it. You can't keep the same thing for the whole week. Every day it has to be changed and cleaned also.
And two last questions. I think participants, you can hold on your questions and then know if some common questions are there, we can put up in the WhatsApp chat box later. We can take it up for the next webinar. So then another one is like, what should be done if drinking water has gram-negative bacteria growth?
Drinking water gram-negative, it's a mostly could be a coliform. It is a contamination, and you have to check your RO water plant or your dispenser whether how it got contaminated. It's a serious issue and you have to act immediately. So yeah, you have to act immediately. Yeah, you should not take it like,
Yes.
yeah.
Yes, doctor. One last question.
Yeah.
So most of the tracheostomy patient, we will send tracheal aspirate for culture. So the result may Klebsiella pneumonia is one of the patient is positive with this bacteria. So sometime other tracheostomy patient may also detect it with the same bacteria. So how can we solve this issue?
Okay, so here the basic thing, no, it is a question between a pathogen and a colonizer. Most of the patients who are on venti or tracheostomy for a long time, they will be colonized with Klebsiella. But is it actually causing infection in that patient? Is he actually having any pneumonia? That is the query. So only in those cases you need to act. If not, just need to be careful that you don't spread this Klebsiella from this patient to another patient, and follow proper cleaning and disinfection of the tracheostomy site and also the venti tubes. Otherwise it doesn't require treatment in cases of colonization.
Okay. So I think we have covered all the questions from the chat box and also from the Q&A portal.
Yeah.
So it was an excellent session, doctor. So
Yeah.
can we hear it from any one of the participants how you felt, as this is the first webinar? So one of the participants can raise your hand so that we can unmute you and we can give you access to talk. Yeah. Jay, can you please? Meenakshi Gujare ma'am, I think so.
Hello,
Yeah.
am I
Yes, ma'am.
audible? I think there's some problem with my video. It was one of the excellent webinars that I have ever attended. Very, in a very simple terms, Madam has explained what we should do and, what are the do's and don'ts. Thank you so much.
Thank you, ma'am, and I'm so happy to hear that it was easy for all of you to understand this topic, because it's a very dry topic. So I tried to
Yes.
make it interesting. Thank you so much. Yeah.
Thank you.
Yeah.
Yes, ma'am, it was very good session because in our hospital when outbreak is happened, that time we are very confused what we will do. So our team is not there and I am a ICN, so we are confused to how to find out the factor. So it was very helpful to us. You are taught us 10 steps how to investigate the outbreak. So it will be easy for me in future if outbreak will happen in hospital.
Thank you so much. Thanks for telling that it was useful and you'll be able to handle your outbreaks confidently. Yeah.
Good afternoon, ma'am.
Yeah. Good
This
afternoon.
was a very, very useful seminar.
Thank you.
You have explained in such a sweet way that we will remember for a long time. Thank you so much, ma'am.
Thank you so much. Yeah. So happy to hear that.
Thank you so much.
Yeah. So,
Yeah, I think, yeah. Anyone else
Hello?
is there? Yeah, yes.
Yes, ma'am, I'm there. Ma'am, this is Suhita. Very good afternoon.
Good afternoon.
I'm an ICM in Chandrapur Cancer Care. It was really a very good session because always we ICMs face trouble in identifying the outbreaks, but ma'am has well explained it. Simultaneously, the most important part I liked was the maintenance surveillance because that is the one thing where we lack. How many days we have to keep on tracking these things? It was really explained well, but last 6 minutes, I don't know due to any technical glitch or I don't know what happened. Last 6 minutes I missed, and I feel I am regretting that why just for 6 minutes I missed the part. So no issue, but thank you so much, ma'am. It was a really important session. Keep on doing this job, and Stella, ma'am, you too. Thank you for um, initiating in such types of programs so that we ICNs can definitely learn a lot of things. Thank you.
Yes, Mrs. Suhita, like you don't have to worry about you
Yeah.
have missed the last 6 minutes. I have seen your comment earlier the moment you have put in the chat box. So it will be live in the YouTube after,
Yes.
it's in live streaming, and whenever you want it for your future reference, you can go back and you can view the video in the YouTube. So you don't have to worry about that. And about this ICN free webinar initiation, it's actually it's idea from Dr. Pari and we all team. So actually, Dr. Pari wanted to initiate this ICN free webinar programs, especially for all the ICN nurses. It should be like not a theoretical part what you're undergoing when you're doing your course modules and all. It is also, this webinars will be helpful when you work as a ICN in the healthcare setting. So thank you so much. Thank you so much for all your feedbacks. And also, as I have said to Suhita madam, you don't have to worry about about the session if you have missed out any of the part due to network error, or in future you want to refer to this course, you can go to our YouTube channel, Skills for Med YouTube channel, and you can watch.
Oh, ma'am, sure. Sure. Thank you, ma'am.
Yeah.
Thank you.
Thank you to all participants, and thank you.